Infective endocarditis represents a serious and dramatic condition that should be diagnosed promptly. So Gilbert Habib will summarize the main echocardiographic features to be examined in patients with suspected infective endocarditis. He will first focus on the assessment of the anatomical changes suggestive of infective endocarditis, like vegetation, destruction of valve, and abscess. Afterwards, he will examine the hemodynamic consequences and the complications associated with the disease.
As you know, echocardiography plays a very important role in the assessment of infective endocarditis. But when we are thinking of infective endocarditis and echocardiography, we think first of transesophageal echocardiography. However, I will try to show you today is that the first examination in suspected infective endocarditis must be transthoracic echocardiography, and that we can obtain several very useful information only with transthoracic echo. So look at this case, and we will begin with a longitudinal parasternal view. And what we can see here already is that there is something wrong in the left ventricular outflow tract. So in this case, we can suspect infective endocarditis, and we can zoom on this zone and look at this abnormal mass moving in the left ventricular outflow tract. The definition of what vegetation is a mass mobile and with a mobility independent to that of the valvular structure on which it is attached. We can also go to the apical view and try to have another view of this abnormal mass on the aortic valve. This is a zoom on the aortic valve, and what we can see here is the left ventricle, the mitral valve, the aortic valve here, and we can see here probably two abnormal masses, probably two vegetations on the aortic valve. The best is probably to stop the image and to go frame by frame and to look at the mobility of this suspected vegetation. The patient, of course, was suspected of having infective endocarditis because of fever and also some signs of congestive heart failure. Here we can make a measurement, a very important measurement of the length of this abnormal mass, the length of this vegetation. We can see here that this one is more than 2 centimeter length. So go now to another apical view in this patient. Of course, this is something abnormal on the aortic valve, but also we have to look at the other valve. We will go further on the mitral valve in a few minutes, but look at also at the tricuspid valve, and here we can see that there is also something abnormal, perhaps a vegetation, perhaps a destructive lesion. And what I would say here is that it is difficult only with the use of echocardiography to differentiate between a vegetation and, for example, a tricuspid prolapse. So now the first step is done. We have a probable diagnosis of infective endocarditis because of a huge vegetation on the aortic valve, and also because we have a suspected vegetation on the tricuspid valve. So the second step of echocardiography in infective endocarditis is to evaluate the hemodynamic consequences of the valve lesions. Here we can see first that we need to quantify the severity of the aortic regurgitation. We are now zooming on the aortic regurgitant jet in the apical view, and we can make the measurement of the PISA of the aortic regurgitant jet. We can here have this measurement, which is 1.5 centimeters, so very large PISA. And also we need the second measurement, which is the continuous wave recording of the aortic regurgitant jet. And if we make again this measurement of the trace of the aortic regurgitant jet by continuous wave Doppler, we can obtain a quantification of the severity of aortic stenosis. And you can see here that is a very severe aortic regurgitation with more than 1 centimeter square aortic valve regurgitant orifice area. But you know also that the quantification of aortic regurgitation is sometimes difficult, and we need to have several methods of quantification. We can look, for example, at the regurgitant jet at the aortic isthmus, and here we can see that there is a very severe reversal of the regurgitant jet in the aortic isthmus, and this is particularly observed in acute aortic regurgitation we got in infective endocarditis of the aortic valve. Another important point is to assess the consequence of the aortic regurgitation on the left ventricular pressures. And there is one very old but still useful sign we can observe in such cases of severe and acute aortic regurgitation. It is what we call mitral prematurate closure. And here we can observe that by M-mode echocardiography, we have a closure of the mitral valve occurring before the beginning of the QRS. So this is a sign of very high, very elevated intraventricular pressures, indicating in general that the aortic regurgitation is severe and not well tolerated. Another equivalent is obtained with an apical view and recording of the mitral flow. Here we can observe that there is mitral regurgitation by continuous wave Doppler, and we can observe what we call diastolic mitral regurgitation, since we have the occurrence of the mitral regurgitation before the beginning of the QRS. And finally, to end this hemodynamic evaluation, which is very, very important in infective endocarditis, we have just to look at the left ventricle and to look at the dilatation of the left ventricle. And here we can see that the left ventricle is dilated in diastole with 66 millimeter in diastole, and also in systole with a 44 millimeter left ventricle in systole. So now we have several information obtained by transthoracic echocardiography. First, we got diagnosis of vegetation on the aortic valve and probably on the tricuspid valve. But we had also a second information, probably the most important, about the hemodynamic consequences of this regurgitation, that is hyperdynamic left ventricle, very severe aortic regurgitation, and high left ventricular pressures. And we probably know that this may indicate surgery in these patients. Now, the first step, and also it is very important, when we have an endocarditis on one valve, we need to go to the other valves. We already saw that this patient presented also with a tricuspid lesion, probably tricuspid vegetation, but we also need to look particularly on the presence of mitral lesions. And if we look in more detail to the anterior mitral valve, we can see that again there is something wrong here on the anterior mitral valve. And if we look with color Doppler in this case, we can see that there is in fact one very important and severe complication of infective endocarditis, which is mitral valve perforation. And we can also look at this perforation probably here if you look in more detail to the appearance of the anterior mitral valve. This is probably an aneurysm of the anterior mitral valve, and the mechanism is the infected jet coming from the aortic regurgitation who creates these lesions on the anterior mitral valve, and finally, which is responsible for the perforation of the anterior mitral valve. And we can see it again in a parasternal short axis view with the perforation of the anterior mitral valve. So the message is, when we have particularly an infection on the aortic valve, we have to look to associated complications, for example, abscess, and probably there is no visible abscess in the case of this patient, but also associated lesions, tricuspid valve, and also associated lesions on the mitral valve. So the key messages from this case is that with transthoracic echocardiography we can get several very important information concerning the assessment of infective endocarditis. We can have information about the diagnosis, but probably the most important is to get information about prognosis. And if we go now to the indication for surgery, we have to keep in mind that the three main indications for surgery are heart failure, embolic events, and presence of perivalvular lesions. This patient presented with severe destructive lesions, mitral valve perforation, and no abscess, but we know that the diagnosis of abscess cannot be done with security only by transthoracic echocardiography. And my final message is, when we are working on an infective endocarditis, we have first to begin with transthoracic echocardiography, but even in this patient, we will need to perform a transesophageal examination because some data may be better observed by transesophageal echocardiography, for example, the size of the vegetation and the presence of a small abscess.
So the key messages are, in patients with infective endocarditis, transthoracic echocardiography represents the first-line imaging, with the goal of assessing the presence of any anatomical changes suggestive of infective endocarditis, to assess the hemodynamic consequences of the disease and any complications.